Hello everyone. Today we're going to be talking about pneumothorax, which occurs when air accumulates in the pleural space and causes the lungs to partially or fully collapse. Pneumothoraces are a common clinical finding, so it's important to understand the physiology behind them. They often occur in trauma patients, but can also happen spontaneously. In some cases, they may be caused by ventilator mismanagement or overly aggressively bagging a patient, which can lead to barotrauma. Our video today comes to us from Tampa, Florida, and before we take a look at that, we're going to talk about a few of the technicalities behind the pneumothorax. And so one of the biggest things to be aware of is that when a pneumothorax takes place, it can cause something called obstructive shock. Obstructive shock is when there's something physically impeding the heart from beating and circulating that blood. We're going to take a look at an image here in a moment, go into some more detail about that. Some other things that a pneumothorax can cause is depressed diaphragm, and of course that obstructive shock can lead to a decrease in cardiac output, which is caused by positive intrapleural pressure. The treatment is to remove the air. So we have air in the chest cavity causing some problems, the lung is collapsed, and so our end goal is to re-expand that lung. We're going to talk about in a moment how to achieve that. Some signs and symptoms of attention pneumothorax. Attention pneumothorax is when where there's enough air in the chest where it's starting to cause some pretty serious symptoms. Those symptoms can be hypotension, tachycardia, low SpO2, dyspnea, distended neck veins. A late sign is tracheal deviation, so you might actually be able to see the trachea moved one side or the other. Diminished breath sounds on that affected side. So when you take a listen to someone with a pneumothorax, the side that's effective, you'll be hearing less air movement in that space. And it can also cause subcutaneous emphysema, which is air trapped underneath the skin. So taking a look here, this image is, of course, of the lung that's being collapsed. So this lung is smaller than this lung, and this has happened because that air, it filled in that pleural space. And so what happens is, as this becomes worse and worse, if there's no intervention had, it starts to push everything to the opposite side. It starts to push everything from the side that's effective over to that opposite side. And as the lung continues to collapse, it starts to pinch the heart. And when that heart becomes pinched, it's not able to circulate blood. And that's how we get that decrease in cardiac output. And again, in order to get that air out of the chest, there's a couple ways to do it. In our video today, they are going to be using a 14 gauge catheter. This is also called a chest dart. And so very simply, it's placed over the rib and sits in the chest cavity. And this acts as a vent and allows air to escape. And when that air escapes, that lung is able to re-expand and the heart is able to beat that lung again. So our video today is of a pedestrian that was struck by a vehicle. Let's jump right into it.
She's behind the Columbia at 21st and 5th. Her boyfriend was hit by a car and he's not breathing. Here, sweetheart. We're right here. Yeah, he's definitely got bleeding and he's barely conscious and his legs are stuck.
Alright, listen, we got help on the way, okay? I don't want you to move him unless he's in any danger and don't split any injuries, okay?
Yep.
Let's get going. Now for you. Auto versus pedestrian. Let's go.
21st Street to the right here.
Control 2 for rescue full. Your patient is coma. Serious leg trauma.
21st Street, which is a two-lane southbound one-way only street.
Right there on the sidewalk,
Streets like that where they're not used to the one-ways, car accidents happen all the time.
Rescue 4 on scene.
All right, load and go.
We get a call for auto versus pedestrian.
Has he spoken to you at all?
No, somebody give me a call real fast, put it on him, let's get the hell out of here.
There was a nurse on scene performing CPR when we arrived. Right away, we know this is going to be a critical call.
Somebody go for a pulse real quick.
He's still on respiration. Let's go.
Hey, come on, let's roll, let's go.
Get him up, going up, and wheeling.
Here's the deal. Crepitus in the back of the head, crepitus in his left arm, his left leg, and his neck.
His neck, we got the collar.
Yeah, the collar's on him. Dude, I need to see the back of that hip. Is it open? Is it shut?
All right, so sounds like this patient has quite a few broken bones. As we can see, his ventilation is being assisted using a bag valve mask because he's not able to take a deep enough breath. So we have some positive pressure ventilation that's occurring right now.
It's open. There's a whole bunch of blood on my hand, so yes. Just breathe for him right now. Let's get him hyperventilated real quick. You got an IO in the right leg.
A lot of times on a critical patient, we'll do IO access. That's basically an IV that goes into the bone. And
These IOs are extremely effective. I've used them quite a few times. They seem like magic. They're incredible.
we're able to administer the medications down through the bone marrow.
No CSF. Pupils are constricted.
Okay.
You got a broken left wrist.
All right.
This guy has multiple fractures all over his body, but our number one priority is securing an airway for this patient, and this patient does not have a pulse, and we don't know why.
Where's my tube? Where's my tube? Good? Fine. That's all I ask.
He's clenched. Somebody give me a little pressure right here, brother.
We need to breathe for him. He's unable to breathe for himself, so we intubate the patient.
That was it right there. That was it right there.
All right.
That was quite an impressive intubation. Sounds like our patient had some clenched teeth. Very difficult to see the anatomy in that circumstance. And so our paramedic here, he probably can't see what's going on, but when you insert that endotracheal tube, when it goes into the trachea, you're going to feel a vibration. There's going to be some clicks. And so those clicks are the tracheal rings that you're hitting. And those tracheal rings, they're not found in the esophagus. So when the view isn't great, but that vibration is felt, that can be an indication that the endotracheal tube has made it into the trachea.
Where those ears at?
How's that feel? How's that feel? Same. Feels same. Resistance? Yeah.
We get the patient intubated, and something's not right.
His color's not looking good.
We're not getting the return that we want from our intubation, from our airway.
Go, squeeze.
32. He may be busted up. Where we at, Bubba?
Go good? He's gone, but he's got some fluid in there.
We have good lung sounds on the right. We have bad lung sounds on the left.
So much resistance. Dude, it's getting harder to back.
See. Hey, we're going to decompress this.
All right. So right there, the big thing for me is our paramedic right here.
Hey, we're going to decompress this dude.
Yeah. So much resistance. Dude, it's getting harder to back.
See. Hey.
So our paramedic right here says, I feel a lot of resistance. It's getting harder to bag them. So when you're bagging a patient, if you start to feel that resistance, that can be a sign of a pneumothorax, because what's happening is now you're fighting that air that's in that pleural space, right? And so as you continue to add more and more, if that pneumothorax isn't relieved, it's going to build up pressure and tension. So if you're bagging a patient and it's getting harder to bag that patient, when you feel that resistance, you need to speak up. You need to tell someone.
We're going to decompress this dude.
Yeah.
He has some sort of fluid in the lungs, and he has pressure on the left side of his chest, which is basically pushing his lung closed, flat.
Decompress that.
Yeah.
What do we got, Bubba? Thank out of it.
That's better.
Good? Yeah. Okay.
So it sounds like that using that chest dart, after they were done, they were feeling less resistance, which is an indication that that tension pneumothorax has been relieved. A couple other things I heard them say was that his color's not good. So he's having decreased cardiac output, right? Because that air is blocking. So his color's not good. His SpO2, we didn't see what it is, but it's probably not good either. And this chest dart is going to temporarily fix that issue. Using a chest dart, it converts a tension pneumothorax into a simple open pneumothorax, and anyone that gets this chest dart is going to ultimately end up with a chest tube.
Thank out of it.
That's better.
Good? Yeah. Okay.
But once we decompress, it allows that left lung to expand. Therefore, we're getting more oxygenated blood through our compressions to the brain, to the vital organs.
Good? Yeah. Okay.
Good, that's good.
Thank out of it.
Starting to get a little color back now.
Definitely the next.
Cool. And it sounds like that they were starting to get more color back, so that obstructive shock is being relieved.
24 hours is going to be very critical for this patient. But he does have a pulse, he does have an airway, and lung sounds. Patient is better than when we found him.
CT, multiple bleeds.
Yeah.
C-spine's clear up to now.
No, C1 maybe.
Oh, that's what it said when they turned his head.
Brain bleeds, so he's got a little ways to go. They say it just stepped right out.
Really? So they were walking him in his girlfriend?
What I got, they just stepped right out. Pop.
And look. Buggy's alive.
All right, so it looks like that we had a happy ending. Really well done by these guys. All right, guys, we're going to be doing one more video on pneumothorax. It's going to be a step up on what happens when that chest dart isn't successful. There's a progression when it comes to successfully dealing with pneumothorax, and so we're going to review one more video about that at a later date. In the description of this video, I'm going to put a peer-reviewed paper from the National Library of Medicine about obstructive shock. If you have time, give it a read. It's a great paper. Obstructive shock is going to be something you're really going to want to become familiar with. All right, guys, thank you so much for watching.